Bulging disc, what it actually means and whether you should be worried. Welcome back to Health Fix Zone. I am Dr. Dan H. And today I want to talk about 3 words that send a wave of anxiety through almost every single person who hears them for the first time. Bulging disc. You went for imaging, maybe an MRI, maybe an X-ray, and the report came back with those words, bulging disc, maybe with a number next to it, L4, L5, L5S1, maybe with additional terminology that made the whole thing sound even more alarming. Disc protrusion, annular tear, mild to moderate foraminal narrowing. And you sat with that report in your hand or read it on a screen and felt something that I hear described by people in our Health Fix Zone community all the time. Fear. The sense that something inside your spine is broken, that your back is fundamentally compromised, that you are going to need surgery, that this is the beginning of a long, painful decline, that your active life, the things you love doing, the movements that make you feel alive, are now behind you. I'm going to spend the next several minutes addressing that fear directly, not with false reassurance, not with vague positivity, with the actual science, the actual anatomy, the actual clinical evidence about what a bulging disc really means, and what it does not mean. Because here is what I know after working with people at Health Fix Zone who have received this diagnosis. Most of what people fear about a bulging disc is wrong. The reality is more nuanced, more hopeful, and more actionable than the diagnosis alone suggests. But some of what people dismiss about a bulging disc is also wrong. There are things you need to understand, things you need to do, and things you absolutely need to stop doing immediately. Today, Dr. Dan H. gives you the complete, honest picture, everything you need to know about a bulging disc, what it actually is, what caused it, what it means for your future, and exactly what to do about it starting today. Let us go. Part 1. What a bulging disc actually is. Let me start at the beginning with the anatomy, because most people who receive a bulging disc diagnosis have never had the actual anatomy explained to them clearly. And without that understanding, the diagnosis remains frightening and abstract rather than comprehensible and manageable. The structure of your spinal disc. Your spinal discs sit between each pair of vertebrae in your spine. They serve 2 primary functions. They act as shock absorbers, cushioning the impact of movement and load on the vertebrae above and below. And they act as spacers, maintaining the height between vertebrae and keeping the spaces through which the nerve roots exit the spine open and unobstructed. Each disc has 2 distinct structural components. The outer layer is called the annulus fibrosus. It is composed of multiple concentric rings of tough fibrous connective tissue, arranged like the layers of an onion or the rings of a tree. These rings give the disc its structural integrity, its resistance to the compressive and rotational forces placed on it during movement and load bearing. The annulus fibrosus is strong, remarkably so. Under normal conditions, it can withstand extraordinary loads. The inner core is called the nucleus pulposus. It is a gel-like substance, composed primarily of water and proteoglycans, that gives the disc its compressive flexibility. The nucleus acts hydraulically, distributing load in all directions simultaneously when the disc is compressed. This hydraulic distribution is what allows the disc to absorb shock so effectively. In a healthy disc, the nucleus pulposus sits centrally within the containment of the annulus fibrosus, centered, stable, functioning exactly as designed. What happens when a disc bulges? A disc bulge occurs when the nucleus pulposus, under sustained or repeated compressive load, begins to migrate away from its central position and pushes against the inner layers of the annulus fibrosus from the inside. Think of it like this. Imagine a jelly donut. If you press down on one side of the donut, the jelly inside moves away from the pressure and pushes against the opposite side of the dough. The dough on that side bulges outward under the pressure of the jelly behind it. Your spinal disc works on the same principle. When load is consistently applied in the wrong direction, typically through repeated forward flexion of the lumbar spine, the nucleus pulposus is pushed toward the back of the disc. It presses against the posterior annular fibers from the inside. Those fibers, stressed repeatedly over time, begin to develop microscopic tears. And as the tears accumulate, the annulus begins to deform outward under the pressure of the nucleus behind it. That outward deformation is the bulge. The disc has not ruptured. The nucleus has not escaped, not yet. The outer annulus is still intact, still containing the nucleus, but it is deformed, pushed outward beyond its normal boundary, occupying space that was not previously occupied, and directly behind the posterior aspect of your lumbar discs, sitting in extremely close proximity, are your spinal nerve roots, the roots that become the sciatic nerve, the roots that travel down into your legs and feet. When the bulging disc pushes into the space occupied by these nerve roots, those roots are compressed, and compressed nerve roots produce the symptoms that most people with a bulging disc experience: lower back pain, shooting pain into the leg, burning, numbness, tingling, weakness, the spectrum of disc pathology. Here at Health Fix Zone, I want to be clear that disc pathology exists on a spectrum. Understanding where on that spectrum your diagnosis falls is critical for understanding what it means and what the appropriate response is. A disc bulge, the mildest form, involves the nucleus pressing against but not breaking through the annular fibers. The outer wall of the disc is deformed but intact. A disc protrusion, slightly more severe, involves the nucleus pushing through some but not all of the annular layers. The annulus is partially compromised, but the nuclear material is still contained. A disc extrusion, more severe, involves the nucleus breaking entirely through the annulus. Nuclear material has escaped the disc boundary and is in direct contact with the surrounding tissue and nerve structures. A sequestered disc, or AMFOS, the most severe presentation, involves a fragment of nuclear material that has completely separated from the disc and is floating freely in the spinal canal. Most people who receive a bulging disc diagnosis fall into the first or second category, and both of those categories, bulge and protrusion, have excellent outcomes with appropriate conservative management. Is a bulging disc normal? This is the question that most fundamentally reframes the anxiety around this diagnosis, and the answer is far more common than you think. Research using MRI imaging of people with no back pain, completely asymptomatic individuals who have never experienced lower back symptoms, consistently finds a remarkable prevalence of disc abnormalities, including bulges. Studies show that approximately 30% of people in their 30s with no back pain whatsoever have disc bulges visible on MRI. By the age of 50, that proportion rises to approximately 50%. By 60, over 60%. Disc bulges are extraordinarily common in the general population. Many of them produce no symptoms whatsoever. The presence of a bulging disc on an MRI does not automatically explain the pain. And the absence of a bulging disc on an MRI does not automatically mean the spine is healthy. This does not mean a bulging disc is irrelevant. It means that the diagnosis alone, without the clinical context of symptoms, function, and individual circumstances, tells an incomplete story. At Health Fix Zone, we always say the same thing: treat the person, not the image. The MRI shows anatomy. It does not show the complete clinical picture, and the complete clinical picture is what determines the appropriate response. Part 2. What caused it and what makes it worse? Understanding what caused your disc to bulge is not just an academic exercise. It is the most practically important information you can have, because the same forces that cause the bulge are almost certainly still present in your daily life, and until they are addressed, the bulge will continue to be stressed, the symptoms will continue, and the risk of progression increases. The primary cause: repeated lumbar flexion. In the vast majority of lumbar disc bulges, the primary mechanical cause is the same: repeated loading of the lumbar spine in flexion, forward bending, rounding the lower back, sitting in a slumped position, bending to pick things up from the floor with a rounded spine, performing exercises that round the lower back. All of these activities apply compressive load to the front of the disc while simultaneously pushing the nucleus posteriorly toward the back of the disc where the nerve roots live. Any single instance of forward flexion under reasonable load is not dangerous. The disc is designed to handle flexion. The problem is repetition. Thousands of forward bending movements, thousands of hours of slumped sitting, accumulated over weeks, months, and years, gradually stress the posterior annular fibers beyond their capacity. The microscopic tears accumulate, the annulus weakens, and eventually the nucleus has enough pressure behind it and enough weakness in the annulus in front of it to produce a bulge. This is why disc bulges are so strongly associated with desk work and prolonged sitting. The sustained posterior nuclear pressure of hours of slumped sitting, repeated daily, is one of the most consistent mechanical pathways to disc pathology. What is making it worse? Right now, here is the part of today's video that I need you to take most seriously. If you have a bulging disc, there are things you are almost certainly doing right now, today, that are continuing to apply the exact mechanical forces that caused the bulge in the first place. Forces that are pressing the nucleus further against the already stressed annular fibers. Forces that are preventing the healing that your body is trying to accomplish. Forward flexion exercises, knees to chest, seated forward bends, toe touches, rounded back movements. Every one of these applies posterior nuclear pressure. Every one of them stresses the exact fibers of the annulus that are already compromised. Every one of them is moving you further from healing, even when they temporarily relieve the muscular tightness that accompanies the disc pain. This is one of the most important messages at Health Fix Zone for anyone with a disc diagnosis. Stop all forward flexion exercises during the acute and subacute phases of disc pain. The temporary muscular relief they provide is not worth the disc stress they create. Slumped sitting, hours of posterior pelvic tilt at a desk, the same sustained posterior nuclear pressure that caused the problem, continuing to apply the same forces every hour of every working day, bending forward from the spine to pick things up, loading the disc and flexion dozens of times every day without conscious awareness. These are the things that must change, not eventually, immediately. Because every day they continue is another day the disc healing that your body is capable of is being undermined. What your body is doing about it. Here is the part of this story that most people with a bulging disc diagnosis never hear, and it is one of the most genuinely encouraging things in the entire field of spinal health. The body has a remarkable capacity to reabsorb herniated disc material. Research using serial MRI imaging the same disc at intervals over weeks and months, consistently demonstrates spontaneous reduction in disc bulge size over time. Studies show that a significant percentage of disc herniations, even moderate to large ones, reduce measurably in size without any surgical intervention. Some resolve completely. The mechanism involves the immune system. Macrophages and other inflammatory cells identify the extruded disc material as foreign tissue because disc material is normally isolated from immune surveillance within the intact annulus. Once the nucleus has broken through or significantly stressed the annulus, the immune system mounts a response that breaks down the disc material over time. This reabsorption process is most effective when the mechanical environment supports it, when the disc is no longer being repeatedly stressed in the direction of the bulge, when forward flexion forces are reduced, when the mechanical conditions allow the body to do what it is biologically designed to do. Give the body the right environment, and it heals far more effectively than most people believe possible. Part 3. What to do and what not to do. Dr. Dan H's Complete Guide. Let me now give you the complete Health Fix Zone protocol for managing a bulging disc. What to stop immediately, what to start immediately, and what the road to recovery looks like when the right approach is applied consistently. Stop immediately, the non-negotiables. Stop all forward flexion exercises. No knees to chest, no seated forward bends, no toe touches, no yoga poses that round the lower back. Until your leg symptoms have significantly reduced and the acute disc pain has settled, these movements are working against your recovery. Stop sitting in a slumped posterior pelvic tilt. This is the sustained mechanical force most consistently driving disc progression in the desk-working population. Lumbar support in every chair, neutral pelvis, both feet flat, movement break every 45 minutes. Stop bending from the lumbar spine to pick things up, hinge from the hips instead. Neutral spine maintained throughout every bending movement. This alone eliminates one of the most common daily sources of repeated disc stress. Stop sleeping on your stomach. Prone sleeping places the lumbar spine in sustained extension that compresses the posterior disc structures. And in people with disc pathology, this is a consistent worsener of symptoms. Side sleeping with pillow between knees, back sleeping with pillow beneath knees. Start tonight. Start immediately. The recovery protocol extension-based positions, specifically the modified cobra, lying face down, initially just resting in the prone position, then progressing to propped up on elbows, encourages the nucleus to migrate anteriorly, away from the posterior annular tears and away from the nerve roots. This is the most directly therapeutic mechanical position for a posteriorly bulging disc. Begin with 5 minutes of prone lying. Progress to elbows up as comfort allows. The legs elevated position, lying on your back with both legs up on a chair or sofa at 90 degrees, decompresses the lumbar discs almost entirely by removing the load of body weight from the spine. 10 to 15 minutes in this position during acute pain phases provides genuine immediate relief without the mechanical cost of forward flexion stretches. The morning piriformis release, figure 4 stretch for 45 seconds each side before your feet touch the floor every morning. Even when the disc is the primary diagnosis, piriformis tightness develops reactively around disc pathology and adds a secondary layer of sciatic nerve compression on top of the disc compression. Releasing the piriformis daily reduces the total nerve compression even when the disc remains the primary driver. Progressive extension exercises, as acute symptoms reduce, gentle press-ups from a prone position, hands under shoulders, slowly pressing the upper body upward while keeping the hips on the floor, creating lumbar extension in a controlled, progressive way. This is the exercise direction that most effectively supports the anterior migration of the nucleus away from the nerve roots. Gluteal and core strengthening, once acute symptoms have settled, glute bridges, bird dog, and dead bug exercises to build the muscular support system that protects the disc from future stress. A well-supported spine with strong glutes and a functional deep core places dramatically less load on the discs than a spine relying on passive structures alone. When to seek urgent medical attention, I need to be completely clear about this because it is a matter of safety. If you experience any of the following alongside your disc symptoms, seek immediate medical attention: loss of bladder or bowel control or function, numbness or tingling in the saddle area, the inner thighs and groin, progressive and rapidly worsening leg weakness, symptoms in both legs simultaneously. These signs can indicate cauda equina syndrome, compression of the bundle of nerve roots at the base of the spinal cord, which is a surgical emergency. Do not wait, do not see if it improves, go to an emergency department immediately. The timeline, what recovery looks like. Here is the honest timeline that Health Fix Zone communicates to our community, because unrealistic expectations lead to unnecessary panic when recovery does not happen overnight. In the first 2 to 4 weeks of correct management, the acute inflammatory response around the disc begins to settle. The most severe pain typically begins to reduce. The neural sensitivity that makes every movement feel dangerous starts to normalize. This phase requires the most discipline, staying consistent with the extension positions, avoiding flexion, maintaining correct sitting and sleeping positions even when it feels difficult. In weeks 4 to 8, as the acute inflammation continues to settle and the body begins its reabsorption process, the leg symptoms typically begin to reduce. The burning and numbness become less constant. The shooting pain becomes less frequent. The disc is being given the mechanical environment it needs to heal. In weeks 8 to 12 and beyond, progressive strengthening becomes the focus, building the muscular infrastructure that protects the disc from future stress, returning gradually to normal activities with the movement patterns that protect rather than stress the spine. For many people, not all but many, this timeline produces a complete or near complete resolution of symptoms, without surgery, without injections, with the body's own biological capacity for healing, given the right mechanical conditions and enough time. Here is what I want to leave you with from today's Health Fix Zone video. A bulging disc diagnosis is not a verdict. It is information, specific, actionable, information about what is happening in your spine, what mechanical forces caused it, and what needs to change for your body to heal. The fear that most people feel when they receive this diagnosis is understandable, but it is not warranted by the actual evidence about what a bulging disc means and what the body is capable of doing about it. Your disc is not permanently broken, your back is not fundamentally compromised, your active life is not behind you. What is required is understanding, correct mechanical behavior, consistent daily practice, and the patience to allow a biological process, the reabsorption and healing of disc tissue, to happen at the timeline the body determines rather than the timeline anxiety demands. You now have that understanding. Stop what is stressing the disc. Start what supports its healing. Give your body the mechanical environment and the time it needs. And trust the remarkable biological capacity that your body has been waiting for the opportunity to demonstrate. This is Dr. Dan H. from Health Fix Zone. If today's video finally gave you the clear, honest explanation of your bulging disc diagnosis that nobody else gave you, hit the like button right now so more people living in unnecessary fear of this diagnosis can find this clarity. Subscribe to Health Fix Zone for weekly videos that replace fear with understanding and confusion with clear, actionable information. And drop a comment below. When did you receive your bulging disc diagnosis and how did it make you feel? Tell me below. I read every single comment and I want to hear from our community. Take care of your spine, give it what it needs. And remember, a bulging disc is not the end of your story. In most cases, with the right approach, it is simply a chapter. I will see you in the next one.